Okay. Well, early bird gets the worm, so I'm going to go get started, and folks can trickle in as they do. I am going to minimize you all so that I can see the slides. So welcome, welcome. Let us know if you can't hear or see. We are excited to have you here for the first combined MCSTAP and MCPAP for moms presentation in the perinatal space. So today we're going to talk about care of pregnant patients with substance use disorder and applying an evidence-based and person-centered approach. And while we really designed this talk for folks who may not have as much experience, or for the sort of OB or primary care generalist who may not care for folks with substance use disorder at a regular cadence, especially in the perinatal space, we hope that there are pearls really for everybody. And so in this virtual world, I always like to sort of bring a little bit of connectedness to this platform. So if you wouldn't mind dropping in the chat your name, introduce yourself, where you work, and hopefully we'll get a little bit of a sense of who's in the meeting together. So I'll have you guys do that. We're also going to use the chat for questions during the talk, and so feel free to drop questions in the chat, and then we're going to save some time for questions at the end as well. And we hope that this is interesting, informative, and if you have other ideas for topics you want to hear about in the future, please just let us know. So with that background, I'm going to introduce us. So I'm Jessica Gray. I'm a family medicine and addiction physician and the Associate Program Director of Mass General Hospital Addiction Medicine Fellowship. I'm also a physician at the Perinatal Hope Clinic and Bridge Clinics at MGH. And most importantly for here, I'm the consultant at MCSTAP. And then I'm going to introduce also Dr. Teslyar, who is a psychiatrist by training, a consult liaison in perinatal mental health. She's the interim director for the Division of Women's Mental Health at the Brigham, and associate medical director of the Substance Use Disorder Program within MCPAP for Moms. So, and we're excited to be here today. So really briefly, what are these two programs that you hopped into? MCSTAP stands for the Massachusetts Consultation Service for Treatment of Addiction and Pain. This is just a general slide of how you can reach us 9 to 5 or via our website, email, or phone call. So what are we? Who are we? We are a group of physician consultants who are state funded to provide virtual support to clinicians to increase their capacity and comfort in using evidence-based practices to both screen, diagnose, treat, and in general manage the care of patients with chronic pain and or substance use disorder. So we offer a number of different ways for you to connect with us. We do real-time curbside consulting via phone. We work with anyone statewide. It does not matter what insurance or if your patient has insurance. We're really here to talk to clinicians to guide them. And again, we're funded by the Massachusetts Executive Office of the Health and Human Services. And so what do we do? Again, in detail, one of the things we do is just, pick up the phone and be able to talk to one of us one-on-one for some personalized and real-time coaching. It can be the first time you call, it can be multiple. We love to sort of follow along with folks longitudinally, and you can do that through formal coaching program that we have, or just informal calling us whenever you have questions. We also offer help searching for resources in your community to address your patient's needs with pain and or addiction. Can offer technical support actually to your practice and thinking about capacity building and infrastructure if you're interested in that. We have these monthly educational case-based webinars, and our website hopefully is useful with a bunch of tools and resources. And I'm going to pass it over to Polina for information on MCPAP.
So MCPAP for Moms stands for the Massachusetts Child Psychiatry Access Program for Moms. We are a program that is also state funded, so it's completely free to use for you and your patients. And we are a service that works in the perinatal space. So we have 3 things that we do: education, like what we're doing right now, and we can also do directed trainings for your specific programs and institutions if you need that. We also provide peer-to-peer consultation services 9 to 5, Monday through Friday, and we usually talk to people who are prescribing clinicians taking care of perinatal patients and help manage that. And we also are a resource and referral service. So you can also call us if you're trying to connect your patient to therapy or psychiatric care or other mental health related care in the perinatal period. And we also have a fabulous website that has some available free toolkits that you can download to help you do this, and also previous webinars like this that have been recorded and are also archived on that website if there's other topics you're interested in hearing about. So this is how you can reach both of us.
Oh yeah, exactly. So we're really excited for, again, this first collaboration together. This is how you can reach both of us. We'll give more at the end. And we have no relevant financial interest or disclosures. And so I'm going to pass it off to Polina to finish the disclosure and then keep going.
Sure. So one thing that I always bring up in these talks is that there are actually no FDA-approved medications to be used in pregnant patients. So everything that we're discussing today is off-label, but that is the case for everything that you would be prescribing to a pregnant individual. Okay, next slide. So the things we're going to be focused on today are learning best practices for initial management of medication for psychiatric and substance use treatment in pregnancy, understanding the rationale behind the universal application of trauma-informed precautions and care in this patient population, and then to think deeply about the complexities of toxicology testing in the perinatal space. Next slide. So why are we all making time for this? This is probably one of the most important things you're going to hear today. This is the data from the Maternal Mortality Task Force, which looks at causes of preventable death in perinatal patients in the United States. And the last time that this data was released, mental health conditions, which for the purposes of this data collection is defined as anything that is like a classic mental health disorder, substance use disorder, and overdoses, both intentional and unintentional, is now number one. So this is now the number one killer of perinatal patients in the United States. And what's very alarming is not only that we're number one, but we've used to be number 5 the last time this data was released. So it's on the rise, and we want to make sure that we can prepare you to help prevent this. Next slide. Okay, so let's talk about how to take care of these patients and what we think about when we do take care of them. So here's a case of a 30-year-old young woman who had a history of very significant trauma in her own childhood, was in DCF custody for some period of time, witnessed intimate partner violence in her childhood, and then also experienced it as an adult. In her childhood, she was diagnosed with ADHD and anxiety disorder, had some school difficulties, began using cocaine and opiates in her teen years. Prior to pregnancy, she had actually been fairly stable on a regimen of amphetamine, dextroamphetamine, and alprazolam prescribed by her outpatient psychiatric clinician. She was also in recovery from substance use disorder. She had an unplanned pregnancy, and when she shared that news with her prescriber at around 15 weeks gestation, they advised her to stop her medication. So not too long after that, she had a relapse on cocaine and fentanyl. She did not establish prenatal care. In her drug relapse, she began to engage in kind of high-risk behaviors that led to her worrying about her safety where she was living because of the people she had been associating with. So she left her apartment. She started to have suicidal thoughts and actually injured herself, and then was admitted to a freestanding psychiatric hospital. Still had not had prenatal care at that point, even though she was well into her 3rd trimester. During her psychiatric hospitalization, she was not started on any standing or therapeutic medication regimen because she was pregnant. They were using PRNs fairly liberally for her management. And at some point she started to have physical symptoms, so she was sent to a more general hospital for evaluation of that. And at that point, that was the first time she was evaluated by an obstetrician and the psychiatry consult service. At that point, she was started again, returned to her previous treatment with amphetamine, dextroamphetamine. and also buprenorphine at her request. I'll tell you more about her treatment course as this talk continues. And then about 3 weeks after starting treatment, both with OB and psychiatry, she actually delivered at 35 weeks gestation due to fetal complications. Her newborn was admitted to the NICU, where NICU staff told her that they would not allow the use of her breast milk to feed the newborn because of the medications she was taking. And she again requested to come off all her medication because it was very important to her to be able to provide milk to the newborn. And so let's take it from there. All right, next slide. So one of the things that happens when we treat perinatal patients is there's a human instinct to not cause harm. And it's also something that we're trained, right? For first, do no harm. The problem is that clinicians are more comfortable making errors of omission than errors of commission, meaning we're more comfortable to stand by and see something bad happen than inadvertently cause harm with our actions. And if there's nothing else that you take away from this talk today, is I want you to recognize that not doing something is causing harm. So we know that untreated mental health issues in pregnancy are very dangerous and can adversely affect not only the care and the health of the patient, but also the pregnancy and the developing child. So patients with major mental illness are less likely to be engaged in prenatal care. They're more likely to be using substances and smoking cigarettes. Those pregnancies are more likely to have complications such as preeclampsia, preterm delivery, low birth weight. Those babies are more likely to be admitted to the NICU. There are more likely to be issues with lactation, bonding. There's more likely to be issues in the partnership with the other parent, and these patients have higher rates of maternal suicide. We also know that there's adverse development on the actual child too. There can be cognitive delays, motor and growth issues, behavioral problems in the school years, and then these kids are also more likely to be diagnosed with mental health issues of their own. Next slide. So this is supported by many years of data that untreated illness can lead to the complications we've talked about. And here's some more details about that. Small head circumference, reduced weight. The newborns are more likely to have excessive crying. They can be harder to console, which actually leads to higher risks of physical abuse. They have higher rates of NICU hospitalization and higher rates of infections. The growth is not as good, and these babies can have sleep difficulties, which again increases the rates that they may suffer physical abuse. And then in the school years, there's strong evidence to support that these kids have higher rates of autism, what's called a difficult temperament, behavioral issues in the school, lower IQ, and increased rates of depression themselves. Next slide. We also have robust epigenetic data to show us that untreated illness can affect future generations to come. So it's not just the patient in front of you. You have to think about the whole lineage at this point. And there's several studies linking maternal distress with epigenetic changes, studies even looking at Holocaust survivors and the effect that this has had on their grandchildren, so even like one generation removed, and differences in the HPA axis in response to stress. A lot of this data focuses on women because it's easier to tell how they're connected to the child. And there's an interesting study. There was a study done after 9/11 in New York City looking at women who were pregnant in Manhattan at that time, and their offspring were more likely to have anxiety and trauma disorders as well. A couple of years ago, they finally did a study looking at men who were adult men but had a history of physical abuse when they were children, and we can even see epigenetic changes in their sperm. So it is important to think about that this isn't just like what's happening now, but causing long-term consequences. Next slide. Bipolar affective disorder is another thing that we are often thinking about in perinatal patients because we know that pregnancy is not a protective state for mood and anxiety disorders. So the relapse rate is very, very high. Patients are more likely to have an episode of depression or mania in the postpartum year than any other time in their life. Some studies say as high as 13% more likely. We also know that the number one reason people have a relapse of their bipolar illness in pregnancy is because they were told to stop taking their medication. So we definitely don't want to be doing that. These are two interesting graphs. The one at the top, the green graph, is showing what happens to patients who stop their mood stabilizer in pregnancy, and basically there's a virtually 100% relapse rate. And then the one at the bottom is an interesting study looking at patients with bipolar illness. The blue line is people who were never pregnant, and the red line is people who were pregnant, and it starts at 40 weeks. So it's looking at postpartum for 2 years. And you can see that patients who were not pregnant but have bipolar illness in that 2-year period, of course, they still have episodes of depression or mania, but about 75% of them don't. Whereas the postpartum patients, only about 10% of them did not have an episode, and this is even with treatment. So the point of this is to highlight the fact that we really do want to make sure people stay in treatment because it's a high-risk time. Bipolar disorder is also very closely tied with postpartum psychosis, so which can be a life-threatening emergency. So we want to make sure that we're also monitoring for that and evaluating for any changes in mental status or behavior, especially in the first 2 weeks postpartum, because postpartum psychosis typically presents very quickly after delivery within the first 2 weeks. And generally in the beginning looks more like a delirium rather than a psychosis because patients present more often like disorganized and confused, and over time start to show psychotic symptoms. Very much an emergency, 4% infanticide rate, unfortunately, with this. So you want to make sure these patients are evaluated in the emergency room. Okay, next slide. When we think about treatment, again, we're going back to, the most important concept is that there is no such thing as a risk-free exposure. We're weighing the risks of untreated illness versus the risks of whatever treatment we're proposing. So in order to come up with a good treatment plan, we want to clarify that diagnosis. We want to know what we're actually treating. We certainly want to optimize non-pharmacologic management whenever possible. And then if we're starting to think about using a medication, we're thinking like, well, where in the pregnancy are we right now? In the first trimester is when we're worried about things like teratogenicity. So maybe it makes sense to hold a specific medication for that and then restart it. Second and third trimester, you're thinking more about like neurocognitive development, growth. In those trimesters are also characterized by very significant changes in metabolism and drug clearance. So you want to be thinking if you need to make a medication adjustment. And then at the end of pregnancy, we're thinking about what's going to happen at delivery time. Is it possible that there's going to be a withdrawal syndrome that needs to be monitored? Is there possible that the newborn will be sedated and might need some respiratory support? How are we going to manage labor, etc.? And then if you're thinking about picking a medication, you really want to start with, well, what has worked in the past? This is the time where you don't want to start trying to make things perfect and break what's good, right? So sometimes we get a call at MCPAP for moms, patient's doing great on fluoxetine. She's been on many other meds that haven't worked, had very serious symptoms in the past, but I'm wondering if I should switch to sertraline because I heard that's safer in pregnancy. Probably the answer to that is no, because if it wasn't effective before, there's no reason to think it'll be effective now, and paroxetine is also safe. We also would like to do monotherapy whenever possible, and sometimes that means we're using higher doses of one drug rather than trying to use lower doses of multiple agents. There's an instinct also to lower doses when a patient is pregnant, but you want to make sure that they're getting the lowest effective dose. So we certainly don't want to create a situation where the patient is exposed to medication and symptoms, because that's a double exposure. So you want to be mindful of that. And then the FDA categories, unfortunately, are very misleading. So we wouldn't rely on those to guide treatment, but you can always feel free to call us and ask. And, so if we go back to the case that I was describing, the medications were stopped at 15 weeks gestation. So we're already out of the first trimester when that happened. That pregnancy's already been exposed. So if the recommendation to stop was because of concerns of like malformations or birth defects, that doesn't make sense, right? So please call us before you make a change. Next slide.
Great. And so I want to again, think more about this case and really some of the cascade of harms that occurred, right? So just to recap on identifying that the pregnancy at 15 weeks, she stops her medications on the advice of her clinician. That leads to a return to use of cocaine and fentanyl. She then has psychiatric decompensation and doesn't establish prenatal care. And again, you heard this, but it is worth repeating, right? This really plays out in an awful way on a population level, right? So this study from research letter from 2022 really highlights what we're seeing across the country, and that is that for patients with a substance use disorder, pregnancy is not protective, right? We have rates of fentanyl and stimulants, psychostimulants, as sort of leading the escalation of overdose year over year. And then notably, the times in which pregnant and postpartum people are most vulnerable to overdose are during their pregnancy. That's the sort of middle line that's going up. And then this late postpartum period. And so just sort of thinking longitudinally, right, the risks don't end and actually increase as you get out sort of past the first part of the postpartum period. And I want to highlight that we have really good evidence-based treatment, especially for medications for opioid use disorder, that does prevent and reduce this mortality. And so just highlighting this study from 2023 that found that medications for opioid use disorder, buprenorphine, methadone, which I'm going to talk about, it was really the only identified factor to decrease risk of postpartum overdose. And so I'm going to dive a lot more into these medications that I'm just going to broadly call opioid agonists. And so what are the benefits of opioid agonist treatment in pregnancy? All the things that you heard that untreated mental illness and untreated substance use disorder can cause. So that's the opposite, right? So being on MOUD increases adherence to prenatal care, reduces illicit drug use and risky behaviors. It keeps the uterine environment less variable. So there's less of fluctuation in maternal drug level and exposures. We see less injection drug use, right? So lower complications from active use. We see maternal nutrition improve due to engagement and care, and we have improvement in infant birth weight compared to untreated. And so what are the risks of opioid agonist treatment in pregnancy? Those are also well documented. So we have an expected neonatal withdrawal, and I'll talk more about that a little bit later. We do see a lower birth weight than non-opioid exposed infants. And then this other area is much more gray and really unclear, but everyone asks about developmental outcomes and infancy and childhood, and really the studies are mixed. You can see how complicated it is if just even hearing about untreated mental illness. And so really teasing these things out is incredibly complex. But so really every single organization nationally and internationally agree that opioid agonist treatment with methadone or buprenorphine is the absolute standard of care for treatment of opioid use disorder in pregnancy with proven morbidity and mortality benefit. And the reason is, and we'll talk again, continue to harp on this, the medically assisted withdrawal, otherwise known as detox, is associated with higher rates of return to use or relapse, and we know that leads to worse outcomes. And so keeping mom stable on MOUD is really first line. And there's an interesting article that just came out in JAMA Health Forum, and that actually looked at buprenorphine specifically. And it was a retrospective cohort study of maternal and infant dyads with a diagnosis of opioid use disorder who enrolled in Tennessee Medicaid from 20 weeks gestation to 6 weeks postpartum. And you can see between the decade of 2010 to 2021. And it specifically, the study looked at buprenorphine treatment versus no treatment in this population. And so excluded were people on methadone or naltrexone or buprenorphine for pain. And what they looked at were these adverse pregnancy outcomes, right? So how do you compare treatment versus no treatment with buprenorphine for preterm birth, NICU admission, infant death, severe maternal morbidity, ICU admission, and maternal death? And it's pretty, it's a pretty positive study, right? That the number needed to treat of a pregnant person with buprenorphine to avoid an adverse pregnancy outcome was 20, right? So these medications really work, and just another study emphasizing the effectiveness. And so you're going to get questions from patients about comparing which agonist they should be in on pregnancy, methadone versus buprenorphine. So just a sort of rapid overview of the two medications. First of all, methadone has been around for 50 plus years at this point, and remains gold standard for pregnancy for all the reasons I've shared. And we know that it, again, both lead to neonatal opioid withdrawal that is treatable. We then, in 2010, had the sort of landmark MOTHER trial in the New England Journal that came out, which was able to compare buprenorphine and methadone, and actually showed lower rates of neonatal abstinence syndrome. Or opioid withdrawal compared to once daily methadone dosing. And really, this is the first time that we got a second medication that is considered first-line treatment in pregnancy. So a real opportunity. And then I'll just point to this study that came out a couple years ago, again in New England Journal, that was a US population level study, cohort study of publicly insured pregnant people who are either on buprenorphine or methadone. So between 2000 to 2018. And they showed that between those two medications, there was really no difference in maternal outcomes. They did find a signal that buprenorphine was associated with a lower risk of neonatal outcomes. And so you might say, oh, should we shift then to say that buprenorphine is better than methadone? And the real answer across the board is that both are excellent medications, and I would not rule out methadone from this study for a number of reasons. And so the take home of all these is you have two very good medications that are both considered first-line treatment. And so then the question becomes, how do you choose, if you're sort of at a point to guide a patient, how do you choose or recommend a specific medication in pregnancy? It really comes down to the practical pieces. So number one, patient preference. What have they been on before? What's worked for them? Number two is access, right? So there are certainly treatment deserts across our state, across our country around accessing, for example, methadone at opioid treatment programs or buprenorphine prescribers. Transportation is often a very real barrier, though hopefully it's getting easier now that we're a little bit more flexible with take-home doses of methadone. And then finally, what is the drug supply? So if someone is getting on de novo MOUD and they're coming off of fentanyl, it has become very hard to get folks comfortably and safely on buprenorphine. It's not impossible, but it's not as easy. So with methadone, right, you can start it same day and get relief without potentially needing to go through withdrawals. And so again, as you're thinking about the risks and benefits, it's really a patient-centered decision. And so how do I think about counseling for opioid agonist treatment in pregnancy in my patients? And the first is really to address patient concerns. So there's a national survey of patients that had highlighted a couple of key concerns that resonated with many and most. So again, the fear of baby's withdrawal post-delivery, the fear of potential child protection services involvement, feeling judged or stigmatized during delivery by being on these medications. And then in other states, hopefully and thankfully not ours for now, is fears of losing insurance postpartum and not having access to those medications. And so once you're able to elicit the patient's concerns around agonist treatment, the next point is to provide counseling that avoids threats. And I still, to this day, have patients share with me that they were told by some provider or someone in the community that if they came off of their medication for opioid use disorder in pregnancy, they would kill their baby. And that's just not true. We are able to safely get people off of their MOUD. It's just that the return to use on a population level is high enough that there is no sort of global fetal or maternal benefit. And so that's why we don't recommend medically supervised withdrawal. And if patients do want to do that, it's really a case by case basis where you weigh the risks and benefits. And I say that because we may have a gold standard, but again, we need to respect patient autonomy. And we have this tendency as a society to think of women as vessels in pregnancy. And that's wrong. You know, that there's so many ethical reasons why that is problematic. But in general, really shared focus on a woman's health will be best both for her and for the fetus. And finally, I'll add for those who aren't prescribing buprenorphine or who are afraid to, don't fear this medication. You can't prescribe methadone, so that's an opioid treatment program. But we want to make treatment more accessible. And so in the case we talked about, and in some cases, really, it's that people are connecting to care. They're connecting to primary care. They're connecting to obstetrical care, but their providers don't feel comfortable prescribing buprenorphine. And so, please call us and keep people on their medication if they're on it. And if you need help starting, that's exactly why we're here. And so, you're probably going to get questions from patients around. Again, the real fear and anxiety around neonatal withdrawal, especially if your patients have done their own Google search. And so it's important to be armed with evidence that you can describe. We know what happens, you know, what can potentially impact withdrawal severity. So I'm just going to run through these. The first in the top middle is that we know opioid agonists, right, that they lead to neonatal withdrawal, and we have some evidence that buprenorphine has a lower level of withdrawal than single dose methadone. I think the more to learn around methadone as a split dose. We know that other medications are implicated in severity of neonatal withdrawal. So the one I have here is gabapentin, but there have been studies demonstrating sort of a worsening of withdrawal symptoms for folks on certain psychiatric medications. Again, that's not a reason to come off the medication, but the idea of using the lowest effective dose and consolidating medications, if able, can help reduce the severity of neonatal withdrawal. There's factors that we can't fix, which is a baby's genetics, and so there's a lot of interesting sort of studies underway trying to understand how genetics and which genetics play a role in babies' withdrawal. Then there's nicotine dependence, which we often see worsening nicotine withdrawal, especially in that first 24 hours. And the last one I want to just mention in the top left up there is thinking about sort of the hospital policies that historically have separated moms and babies. And we have great evidence that rooming in, using evaluations for withdrawal, such as Eat, Sleep, and Console, as well as using like as needed PR and rescue medications versus standing medications when needed, actually reduce length of stay and severity of neonatal withdrawal. And really that parental presence, breastfeeding, skin to skin, rooming in have really been shown to reduce withdrawal. And finally, the drug supply is crap, right? Literally is, there's so many adulterants that we don't know about. One of them we know more about is xylazine, which has some scary potential implications for pregnancy and fetal development. And so just thinking about, again, the importance of getting folks on a safe supply of medication to treat opioid use disorder and away from the drug supply. So a word on breastfeeding and substance use disorder. I'll frame this with people have the right to feed their babies how they want to, as long as it is safe, right? This is breastfeeding really should be considered a right and not a privilege. And so sort of thinking about folks with substance use disorder, it is absolutely safe and a positive, right, for women who are on MOUD to breastfeed. And so really encouraging breastfeeding in women who are stable on methadone or buprenorphine is gold standard unless there are some medical contraindications, which are few and far between. So hepatitis C is not a contraindication unless you have active cracked and bloody nipples. But without that, it is safe to breastfeed with hepatitis C. In the United States, HIV infection is a contraindication, so not recommended. And then from Dr. Teslyar, you can ask more questions at the end, but there really are no absolute contraindications to breastfeeding with psychiatric medications. Some of them, like lithium, require additional close monitoring, but again, before you make any med changes, please call MCPAP. And so highlighting a wonderful publication that came out in 2023 revising the Academy of Breastfeeding Medicine recommendations for substance use disorder. There's a QR code up there to link to it. I just want to highlight a couple of things as we think about breastfeeding, really, again, as a human right. So the recommendation is that really individualized care plans should be created in partnership with the patient and the multidisciplinary team with the appropriate clinical support and follow-up. Again, so this is really individualized care for folks with a substance use disorder. And we used to think that you actually needed to be sober for 30, 90 days in order to be eligible for breastfeeding. And this applies to the case that we've been talking about. But we know that most substances are eliminated in hours to days rather than sort of days to weeks. And so the current breastfeeding decision-making that's supported by the National Academy of Breastfeeding Medicine is that breastfeeding is recommended among mothers who stop non-prescribed substance use by the time of delivery. And again, not every sort of hospital is practicing this, and I think it's worth thinking about how we really support people in their feeding goals and keeping families and babies safe. And that means understanding that there's real limitations that are listed in this reference to what we know, and the absence of, as Polina said, the absence of evidence or doing nothing doesn't always is not always the safer option or the better option for a baby. Okay, so a few words on optimizing the specific medications in pregnancy. I think these are sort of broad strokes important to know about methadone and buprenorphine. So first of all, methadone is metabolized in the liver, and pregnancy is a known state of rapid metabolism. As the liver revs up, the once daily dosing of methadone no longer is effective for the majority of pregnant patients, and that's because they're just breaking down the medication faster. And so really the only way to optimize the dose to be in a therapeutic range is to have what you can see in the red line or pink line, which is a split dosing. So dosing twice a day versus once a day, where you feel over medicated on a high dose at peak, and then you're in withdrawal before you're due again. And so this is actually an active time. Unlike most patients who are on methadone, once you get your stable dose, you kind of are there for a while. Pregnancy actually needs a lot of dosing adjustments, really throughout all the trimesters. And it's helpful to remind patients that this is really due to a change in their liver metabolism. It's not a marker of their disease getting worse. And every patient should be offered a split dose to maintain a therapeutic level, though there may be reasons why certain patients actually don't want that, which is fine too. And so what does the literature say about methadone in pregnancy? First, that we expect that your dose will go up, that there's evidence that higher dose actually corresponds with less illicit drug use and vice versa, and that we see racial inequities, just like we see in the rest of medicine, identified with who gets on sort of a more therapeutic dose at delivery. Some methadone clinics are still sort of artificially saying this is the maximum dose you can go on, and that's not advised. We do know that buprenorphine leads to less severe withdrawal than once daily methadone dosing, but more and more, I think evidence is coming out that split dosing of methadone improves maternal and neonatal outcomes, and I think the jury's out as to whether that actually balances buprenorphine. If you're seeing women postpartum, what do you need to think about who are on methadone? First of all, that this is a medicine that needs to be optimized for a postpartum mom to be at her best. If she's got a dose that's too high, then you risk oversedation, overdose, safety issues such as falling asleep, holding the baby. If it's too low, you have a very uncomfortable mom who may be at risk of return to use. Unfortunately, what we know about metabolism in the postpartum period is that it's really variable, and it's really needs to be an individualized approach to adjusting methadone after delivery. So rapid changes are not recommended unless someone's very over medicated, and really what we don't want to see is someone postpartum smushing all their twice daily dosing of methadone to once daily, because it really can cause them pretty significant side effects. And so a few words on buprenorphine before I pass it back over to Polina. So first is that similar to methadone, buprenorphine, we find that in pregnancy, the plasma concentrations can significantly decrease, and people need to often, but not always, increase their dose of buprenorphine. And we find that splitting the dose to 3 or 4 times daily may actually be helpful for sustaining plasma concentrations and avoiding withdrawal symptoms. And so what about, I get this question a lot, what formulation should I be using in pregnancy? Do I need to switch the patient to the mono product, for example? And the answer is you don't have to make a switch, and that we have a meta-analysis from 2020 which looked at comparing the two formulations, and it was reassuring. Right? We're not seeing a difference in outcomes. Note that all the studies initially in pregnancy were actually done in the mono product because that was the first one that came out. And so we just didn't have the combination product when these studies were happening. Of course, we'd always like more prospective data, but there's really been no evidence for concern on teratogenicity for the naloxone component. And so the recommendation is, if the patient wants to continue with that current formulation, that makes a lot of sense. There's reasons why switching formulations can be destabilizing, and just the way we practice it at Mass General is that we offer women informed choice. And so that means if they want to switch to the, if they're on the combo, they want to switch to the mono product during pregnancy, that's their right, but I would not hesitate to keep someone on their combination product if they feel comfortable on it. And so what about all the long-acting injectables that have come out? There's a lot of benefits overall in the general population to the long-acting injectable buprenorphine, right? So it really overcomes barriers to remaining on treatment. You don't need to daily dose someone. It provides you a steady state of continuous buprenorphine that slow releases over either a week or a month, depending on the formulation. You actually get higher serum levels consistently than you do with the sort of peak and trough of sublingual, and it avoids intolerance to sublingual formulation, which can be really bothersome and challenging, especially with nausea in pregnancy. It also may protect, some from child safety because you don't have medications at home. The challenge in pregnancy is that we don't have much data, right? So the weekly formulation is the only one that's been studied in pregnancy. We are waiting for the results of that national trial to come out. So right now we just don't have a ton of data, but it's important to know that none of these injectables are contraindicated. However, because of the limited data, really, we require shared decision-making. And what I would say is that one of the Sublocade, it was the initial medication that came out of the long-acting injectable, and there were initial data that potentially the atrogel component had a risk for teratogenicity in animal studies, but human data has not borne that out. And so really, I would not rush to make any change, and just call us if someone's already, exposed in pregnancy or is planning a pregnancy. We're happy to talk through some of the nuances. And so I'm going to pass it on to Polina.
Okay, so we'll switch gears a little bit and start talking about trauma-informed care and trauma precautions when working with these patients. Next slide. So back to our case and our patient. So she spent some time in the general hospital getting treatment, and not an easy hospitalization or an easy course. She would be what we would call a difficult patient. There was a lot of conflict with staff, a lot of miscommunications. She was often perceived by staff as like overly demanding and difficult to work with. She was very easily agitated and clearly became quite overwhelmed, which affected some of her care and dispo planning and sort of the options that were at the end available to her because of that. So next slide. So what is trauma? SAMHSA has a very nice definition of trauma that they define as an event or series of events or circumstances that are experienced by the individual as physically or emotionally harmful or threatening, and that has lasting adverse effects on the individual's functioning, physical, social, emotional, or spiritual well-being. Next slide. What's interesting is that there are certain traumas that are very obvious and are well recognized both by clinicians and by patients, right? Like war, famine, rape. Everybody kind of understands those as traumas. But we often forget about is the things that are in research called adverse childhood experiences, or sometimes you'll hear people say like little t traumas, the things that patients themselves may not describe or identify as traumatic because it was part of their environment, part of how they grew up, right? So things like having a mother with depression, having a history of being abused, having a parent with a substance use disorder, witnessing domestic violence in the home, experiencing homelessness, incarceration, divorce, neglect. And then, things that are happening in the community, like maybe violence where they live, discrimination, disruptions to the community network, poverty. And a lot of these things patients don't necessarily recognize as something unique to them because it's in the milieu, but they can still be very traumatic and can cause a lot of long-term consequences. Next slide. We know that in this patient population, trauma is nearly universal. I will say that, my career is not measured in many decades yet, but it's long enough that I can confidently say I have never met a pregnant patient using substances who did not have a comorbid mental health diagnosis or some level of trauma in their lives. The studies will tell us that 55 to 99% of women with substance use disorders have a history of physical and sexual abuse. We also know that it's a bidirectional relationship in the sense that people with a history of trauma and a history of abuse in their childhood are far more likely to then go on to develop substance use disorders, both with alcohol and other substances. We also know that intimate partner violence is more common in pregnant women than gestational diabetes. But if you think about it, how often are those things being screened for and addressed? Next slide. We also know that the maternal experience of trauma and the sequela can have negative impacts on the pregnancy and the infant as well. Obviously, traumatic experience can exacerbate underlying mood and anxiety disorders. It can impair bonding. It can lead to early cessation of breastfeeding. There's a higher rate of preterm delivery, again, low birth weight. And we also know that these infants can be harder to soothe. They have a dysregulated nervous system. Next. And so how does this affect you? How does this affect your relationship with your patient? Well, patients with a history of trauma may misbehave in the medical setting. They may miss their appointments. They may cancel repeatedly. They may avoid coming to care. They may not adhere to your treatment recommendations. They often are also more likely to have unexplained chronic pain syndromes. And they can be nervous about medical procedures, which again can make it harder to give them the evidence-based care that you want to provide. Next slide. The other thing that's really important to remember is the healthcare setting itself can be very traumatic. And especially for perinatal patients, it's very common that patients who have a prior history of childbirth will have had a traumatic experience that was never addressed or identified that way. And so they may go, they may have had a very scary childbirth experience. In the aftermath, they may just feel grateful that they recovered and everybody survived, and it's never addressed again until they're again pregnant, and now they're flooded and anxious and maybe having flashbacks and are avoiding their obstetrician's office and sort of like sometimes they themselves don't have insight that this is happening and this is why they're having trouble. And so it's really important to kind of address that directly. We also know that no matter how hard we try, we're all still human and we have our own prejudice and biases. And sometimes this can come through in our care for the patients. And so patients can actually, from us, also experience stigma and feel discriminated, which then leads to wanting to leave AMA, which then reinforces the idea that this was a difficult patient. And also these patients are often undertreated for their pain. Their withdrawal symptoms can be undertreated, which again leads to kind of premature disruption of care. Next slide. So we should be cognizant of our role in this, right? There's an inherent power dynamic difference in a treatment relationship. The patient is coming to you because you're the expert. You're the one that's the authority figure in that space. There could be issues around gender and gender identity. Do they feel comfortable with a provider of a particular type of gender or not? Hospitals are notorious for being places where privacy is not respected, right? If the patient's being evaluated in the emergency room, I know in our busy emergency room in the Brigham, it's very often in the hallway, even though we may be talking about very sensitive issues. The same may be true if they're in L&D triage, like, are they worried about being overheard? And then there's also the physical space. Are they in a comfortable situation? What are the positions of us versus them? Physical touch. We often, especially in pregnancy, patients need to be touched to be evaluated, right? They need to have fairly invasive routine exams. What's the conversation around that? What's the kind of anticipatory guidance and permission seeking when doing that? Next. So, also thinking about why patients may not show up to their care because they may feel the stigma, they may feel ashamed, they may feel like it's hopeless, there's nothing to help them. They may have a partner who's really hindering them being proactive. They may also fear the consequences of DCF being involved. And then on our side, we may not recognize what's happening. We may not have the language to recognize that this is why we're having difficulty in this treatment relationship, and being aware of our own behavior. Next slide. So when we are thinking about trauma-informed care, we want to make sure that we're always compassionate and empathic. For me personally, it's always helpful to remember that I've never met a pregnant individual who was not doing their best to make healthy decisions for their pregnancy and their fetus. And so if the patient is using substances, it's because it's a health problem, right? It's a higher level health issue, and that they need help with that. Giving patients as much choice and control as possible and is safe to do, validating their concerns, listening to them, but also helping them promote their own resilience and problem solving, and asking, how can I help you? How can I support you right now? Next step. Slide. So we also want to be thinking about ourselves and what we're contributing to the interaction. So you want to be calm. You want to think about your own response, your own stress. You want to not escalate, but contain. You want to focus on the patient's coping style and how to help them. With this patient in particular, there was a very telling moment where she kept asking for something to treat her anxiety, and I was going through all the options, and she kept kind of screaming at me, I don't want anything, I just give me something. And I didn't understand that communication. I couldn't understand what she was asking me for until, a staff colleague helped me understand what she's saying is, stop giving me choices, just give me a treatment. And so kind of listening in a different way and understanding what the person is trying to communicate, even when it feels like it might be contradictory, and focusing on their goals and values. Go ahead, go to the next one. So again, the core principles of trauma-informed care are safety, trustworthiness, and transparency. If we say we're going to do something, we really need to follow up and actually make that happen. Peer supports, collaboration, empowerment, respecting the patient's cultural and historical gender background and how that's affecting things, and making sure that they feel safe with us. Next.
Awesome. Okay. I'm going to wrap us up in the last few minutes and just touch at a high level on some of the complexities of toxicology testing in the perinatal space. Again, if you have questions or other topics you want to throw in the chat, I know that we're going to end soon, but key things to take away about testing and screening. So drug rapid use screening, is a set of verbal or written questions asked to the patient to identify concerning substance use. That is very different than testing, or toxicology testing, which is a method of determining if someone has had recent drug or alcohol use, whether it's, any bodily sample, urine, blood, or saliva. So toxicology tests or drug tests are not screening tools. And that's probably the most important thing I can say. And so what are these assumptions on drug tests that folks have? One is that it accurately captures recent drug use, that it identifies addiction versus recreational use, that we have a federal law requiring us to test and report, and that illicit drug use itself causes significant developmental harm. These assumptions are actually all wrong. And so the reality is that interpretation of drug testing is complex. It is not black and white. Especially in pregnancy, these tests have incredibly real legal and social consequences beyond your clinical encounter, and that can often lead to an environment of mistrust and fear because people won't show up if they need to have a toxicology test. And there are some real downstream consequences that are well documented of perinatal drug testing. We know that people use drugs at the same rate by class and race, and yet poor women, Black women, and other underrepresented minorities and underserved communities are more likely to be tested, which leads to the cascade of reporting and loss. And so when you're thinking about testing, this is from the American Society of Addiction Medicine and the American Academy of Addiction Psychiatrists, it's important to, one, know your state's requirements on mandatory reporting and ramifications for reporting, weigh the potential benefits with the risks of utilizing drug testing in this population, and then informed consent. So these are my toxicology testing principles. Happy to dive in further if there's interest at a little later time, but it is just as you're thinking about whether or not it makes sense to get a toxicology test, you want to acknowledge the realities of the broader carceral systems that you're sitting in. Absolutely do not ever, in pregnant or non-pregnant people, get a toxicology test without explicitly asking consent. And in pregnancy, we've really moved to actually requiring written consent in our hospital system. Be able to explain how the results will change your clinical management. So what are you going to do if there's an unexpected test? How are you going to interpret whether it's a preliminary or a confirmatory test? Again, understanding the test itself. And most importantly, if you're getting the information from a patient and you've built that trust on reporting if they're struggling with a substance and use, you don't need a test to sort of demonstrate what you've already confirmed verbally. And so finally, appreciate patient autonomy. Patients are allowed to decline a test, whether or not they, have something to disclose, and really building a trusting, trauma-sensitive environment where a patient can have an honest conversation with you is most important. And so I'm going to actually stop here because this is just a summary of what we've been talking about. And I'm going to really thank everyone for coming. Here's our contact information. Folks want to stay for a couple of minutes, happy to answer questions. Otherwise, you'll get an email from MCSTAP and MCPAP about CME for this, and we appreciate your time. So I'm going to stop sharing.